Good afternoon, everybody, and sorry for the delay because of inadvertent reasons. And today we're going to focus about a very, very important topic of precocious puberty, which is a common manifestation in terms of clinical pediatric endocrine practice. And we'll try to cover the various aspects of this disorder, how to evaluate, how to assess and manage. And this is part of our postgraduate lecture series. Precocious puberty is a common finding which we observe in terms of our clinical practice. And the main reason why we are concerned about this is that there could be long-term issues in terms of the growth and in terms of other parameters. So what are the major causes as far as the precocious puberty in girls are concerned, Dr. Dhwani?
Precocious puberty could either be central or peripheral. The most common cause of central precocious puberty is idiopathic in girls. Other causes of central could include CNS lesions like neurofibromatosis or.
So when would be the situations, Dr. Alapan, when you think about these pathological causes?
The presentations are either like less than 6 years old, or there is any neurological pointers that indicate towards features, or there is any discordant pattern that would indicate.
So we will discuss about what are the pathological pointers in terms of precocious puberty. So we have to understand that many patients who come to us with precocious puberty may not really have precocious puberty, while many cases who may have some pathology, we may be missing out on that. So we need to have our eyes and ear open in this regards and balance our evaluation. So we had this 7-year-old girl with thilarchy who presented to us with complaints of breast development. Stage 2 breast development was there. The bone age was normal, was advised GnRH analog. But the first thing which you should do as a clinician when you have encountered by somebody who comes to you with precocious puberty is really if there are features of precocious puberty or not. So this girl, her bone age is not advanced. We started thinking, okay, this may be something else. So we got the evaluation for vaginal mucosa, and which was red. Now we need to remember is that this red vaginal mucosa will mean that there is no estrogen exposure, making precocious puberty less likely. And in this scenario, when we actually palpated, we found that this was not really a true breast tissue. It was lipomastia. And in this setting, we don't need to worry about in terms of really whether there is a pathology or not in further workup. So the first thing is to not unnecessarily label somebody as precocious puberty in that regards. On the other hand, we had an 8-year-old girl with thilarchy who presented with stage 3 breast development and also pubic hair development. And this girl was tall for this 8 year of age. She had an advanced bone age, and on investigation, it was found that the estrogen levels were very, very low. So the treating physician basically reassured that since estrogen was normal, there is no need to work up. But this is completely different from the previous case where what we have found that this girl is taller, has a more advancement as far as bone age is concerned, and the LH level is on the higher side. Now, as I'll discuss subsequently, estrogen is not a good marker of pubertal status in girls because of the issues of assays, particularly the chemiluminescence assay. So giving a reliability as far as estrogen is concerned is not an appropriate way, and we should really have gone ahead in terms of clinical evaluation and managed, and it was found that the vaginal mucosa was really pale, and this level which we found was actually falsely low. So this definitely would require evaluation and management from this clinical perspective. So precocious puberty, as we were discussing, is a common presentation. Approximately 1 in around 40 to 1 in 400 will have precocious puberty. In girls, most of them are physiological. Some of them are pathological. So we need to really have a balance in not doing too much workup in somebody who has a physiological cause while not missing a pathological cause in that perspective. All of you can have a look at our website, learning.growsociety.in, which has got a lot of resources in terms of pediatric endocrinology, including our YouTube channel, which has got free resources our website, which provides courses in terms of pediatric endocrinology, including fellowship and pediatric endocrinology for postgraduate courses. We run frequent programs in terms of postgraduate lecture series and grand rounds, which stream information about pediatric endocrinology and have multiple publications covering the entirety of pediatric endocrinology. We are very soon coming up with our basic pediatric endocrinology second edition, which is already available in the Amazon scenario in US and other European countries and would be launched soon in our scenarios. Their mobile applications will guide evaluation and management. And coming back to our this lecture, we'll talk a bit about the pathophysiology, then focus about etiology, management, and we'll also have a Q&A session at the end from a more perspective in terms of the OSCE scenarios in that regards. So when we talk about precocious puberty, we are talking about three major organs: the hypothalamus, the pituitary, and the ovary, and three major hormones: the GnRH, gonadotropins, and estrogen. It's the synergy between these which cause the development of precocious puberty. So GnRH is the central part as far as the regulation of puberty is concerned. It is produced by the hypothalamus in a pulsatile fashion. It is controlled by a both negative as well as positive pathways. So we've got GABA and MKRN3, which is suppressing puberty. Now, what you need to remember is that the puberty is actively suppressed, and removal of the suppression is the most common cause of trigger of precocious puberty in that regards. There are stimulatory pathways, glutamate and kisspeptin. In general, the inhibitory pathways are superior and they are taking an edge as far as the stimulatory pathways are concerned. And in optimum scenario, when the nutrition is good, when your kisspeptin is good and your inhibitory pathways go down, then the pubertal onset happens in that regards. This GnRH then produces LH, which acts on the LH receptor in the theca cell to produce androstenedione, which is converted via the granulosa cell using aromatase enzyme under the influence of FSH. So both LH and FSH are required for pubertal development in girls. Conditions which are associated with isolated LH excess, like HCG producing tumor or testotoxicosis, do not cause precocious puberty in girls, while they can cause precocious puberty in boys, because in boys LH alone can produce your testosterone. On the other hand, if you have very high level of FSH, you do not need that much LH to produce estrogen. So high FSH state can cause precocious puberty in girls, and the classical example of that is hypothyroidism, wherein very high levels of TSH act on the FSH receptor to cause this development of large ovarian cyst and precocious puberty from that perspective. Now, the estrogen can also be produced peripherally using the adipose tissue aromatase, which converts the androgens produced via the adrenals or the ovaries to estrogen. So obese children are also more likely to develop precocious puberty, partially because of peripheral conversion. However, because this is not really a true central precocious puberty, this will represent what is known as a slowly progressive precocious puberty. And it's been shown that many of these individuals have an increased gap between thelarchy and menarche. So while the thelarchy is happening earlier, the menarche is happening at the right time, and that's why this is a slowly progressive precocious puberty, which does not require treatment from that regards. Now, estrogen acting on the estrogen receptor causes stimulation of the breast growth, growth plate development, and uterine growth in that perspective. We also need to understand is that the adrenals play a very, very important role in regulating pubarchy. So gonadarchy and pubarchy are separate phenomena. The change in odor, the acne, the development of pubic hair is all dependent upon adrenals. So there may be a discrepant development which is happening in terms of adrenals and the gonadarchy. Similarly, when we are treating a particular individual with GnRH analogs, we will only be affecting the ovarian production of estrogen. We will not be influencing the adrenal production. So often you will have parents who will say, okay, with GnRH analog, the breast development has come down, but the pubic hair growth is continuing, which is a normal expected phenomena, because this is not going to have an influence in that perspective, and this is what regulates the pubic hair. As I've said, TSH is a glycoprotein. It has got a structural homology with FSH. Very high levels of TSH will cause increased FSH activity, producing large ovarian cyst, peripheral precocious puberty, a form of precocious puberty in which you will have delayed bone age and short stature. Every girl who has precocious puberty should be tall. If you have a short girl with precocious puberty, think hypothyroidism as a strong possibility in that perspective. Now, as we have discussed, the usual scenario is that once the body is mature enough, the kisspeptin signals that, okay, this is the time for GnRH neurons to trigger, and we start having these pulses resulting in precocious puberty. Now, as I've said already, that in obesity, your fat is more, you will have more aromatase that will produce more estrogen, resulting in a peripheral production. Another mechanism by which the body weight status links with pubertal development is leptin. So leptin has a permissible effect as far as pubertal onset is concerned. So if you have got more leptin, the body will then be ready to enter puberty. But just by having more leptin, you will not enter puberty because the inhibitory signals are suppressing. There is also 17 beta HSD, which produces testosterone, which is then aromatized from that perspective. An important aspect, as I discussed, is the overlap between glycoprotein hormones who share their alpha proteins, while their beta pep chains are having a different structure, but still they have an overlap. So TSH has an overlap on the FSH receptor, resulting in a large ovarian cyst and peripheral precocious puberty in girls. Now, as I've discussed, there is a distinct regulation of different aspects of pubertal development. Adrenals are regulating your androgen production, while the ovaries are regulating the estrogen production. So breast and pubic hair, these are two different sets of organs regulated by two different groups. Under normal scenario, you expect the breast development to be commensurate to the pubic hair development, but you may have discrepancies in this scenario. So in scenarios wherein you have a gonadotropin dependent precocious puberty, you would expect that you will have growth of both in the scenarios, and you will have breast development as well as pubic hair development, which will happen. However, if you have a scenario in which you have got a lot of estrogen production because of ovarian cyst, you would not have adrenal androgens. And in this scenario, you will have a rapid progression in which breast development is there, but there is no pubic hair development. So again, a correlation between breast and pubic hair will give you the right diagnosis. An interesting scenario which is there is hypothyroidism, in which you will have a lot of TSH acting on the FSH receptor, resulting in production of breast development, while pubic hair development will not happen. So you will again have breast development and no pubic hair again, which will give you a clue. And of course, if you have a primary adrenal problem, there will be no breast development and you will have a pubic hair development in that scenario. So a basic evaluation in terms of pubertal assessment for breast and pubic hair will give you a clue as to which way you are heading to in that perspective. Of course, when you're looking at precocious puberty, you need to be very careful in terms of your pubertal evaluation. And we know that stage 2 breast development is the onset of puberty. And in this regards, it's papilla elevation, but you should always confirm it using a palpatory method. So while Tanner staging is largely based upon inspection, stage 2 may need to be confirmed using palpation in obese individuals, because this is one scenario in which you will have a false diagnosis which may happen. This is a time when growth spurts happen, and it is approximately 2 to 2.5 years from breast stage 2 to breast stage 4 and menarche in that regards. And typically, you will gain approximately 15 centimeters till breast stage 4 and additional 5 to 8 centimeters subsequently. So there is a 20 centimeter increase which happens in terms of pubertal development and height development from the start of breast development. So anything which is B2 and above means the puberty has really started in that perspective. Vaginal discharge may also be a surrogate marker, because this is the time now that the girl is very close to menarche, typically around 6 months from menarche in that regards. Now, very importantly, it's not that everybody will go through the same phase, the 2.5 years between breast development and menarche. If somebody is a SGA, you have to be really, really concerned, because the SGA will have a rapid pubertal progression and you don't need to wait much in that perspective. However, in obesity, I said that the puberty is not really central precocious puberty. It is largely because of this peripheral conversion. There, this gap may be more. So BMI, I think, will be an important parameter to look at when you talk about slowly versus rapidly progressive puberty. And earlier the onset, the more likely it would be that it's a slowly progressive puberty. Of course, if it's very early, before 6 years, that's a different thing. But between 6 to 8 years, often you see that the thelarchy is early, but the menarche is happening at the same time. So the gap between thelarchy and menarche is increasing. Always look at pubic hair, and remember, P2 is very, very common. So what we are looking at in terms of P2 is that if there is any increased hair growth compared to the abdomen, that is stage 2 development. But what we are really concerned about in this regards is the stage 3. So stage 3 is characterized by longer, thicker, curly, pigmented hairs, while P2 is more of a vellus hair and just small. So if it's P3 and above, I'm really bothered about. P2 is something which may not be very, very significant. Then you have the lateral spread and the adult distribution. So without breast and pubic hair development, do not go ahead with making any particular diagnosis. You need to be very sure as to what you're looking at from that perspective. Usually, thelarchy precedes pubarchy, but in 15% thelarchy may actually happen after pubarchy. So this is common, and you may have discrepancy. And axillary hair usually start 1 year from pubic hair development in that regards. Now, as I've discussed, there are two major hormones, LH and FSH, which we assess in terms of pubertal regulation. Now, what you need to remember is that the FSH is already high during early stage of development. FSH level increase by around 2 to 3 times during the duration of puberty, FSH levels, while LH level increase by around 10 times. So LH is a much better marker of pubertal onset as compared to FSH. And now with the ultra sensitive assays which are available, if your LH is more than 0.2, generally it means that the puberty has already started. The role of GnRH stimulation test has now come down because of this availability of better assays. Because earlier we were using 0.6 as a cutoff, and then often GnRH stimulation test was required. Similarly, as your estrogen goes up in the initial phase of the levels, your uterine volume and ovarian volume are pretty similar. But as time progresses and your LH is rising above, you will see there is a significant increase in uterine size, and the change in uterine shape from a tubular structure to a globular structure is the first sign of development of puberty in terms of uterine growth. Increase in uterine length by more than 34 mm, endometrial thickness beyond 3 mm clearly mean that you're entering into a progressive form of puberty. If its endometrial thickness becomes more than 5, you're very close to menarche from that perspective. So understanding of what you're looking at becomes important. And if your volume is more, you will have to be careful in that regards. Now, from clinical perspective, when you talk about precocious puberty, it could be because of the hypothalamus or pituitary, which is the central precocious puberty. And we've discussed that most girls have a central precocious puberty. And in this scenario, you have a concordant development. Usually it is idiopathic, but there could be certain individuals who may have a pathological cause. While peripheral means largely ovarian or adrenal estrogen production or exogenous, and this is characterized by hypogonadism. So your LH and FSH levels are low. It's a discordant pattern, and usually it's more likely to be pathological. Central precocious puberty, as discussed, could be idiopathic, but this can occur in the setting of CNS tumors in terms of malformations, any insult, including radiotherapy, which becomes important in that regards. There are a few genetic causes which are also there. The peripheral causes, the most common important will be ovarian cyst. And ovarian cyst is usually common for most causes. So whether you have a functional ovarian cyst, whether you have hypothyroidism, or you have McCune-Albright syndrome, all of them will have a form of ovarian cyst in that perspective. And these conditions become important. So precocious puberty could be incomplete, thelarchy, pubarchy, or menarche, or complete, in which all aspects of pubertal developments happen. It could be central, in which it's idiopathic in most cases, organic because of CNS lesions or rarely genetic causes, or insult, and peripheral, which could be because of ovarian origin, because of ovarian cyst in McCune Albright, hypothyroidism or cyst, rarely adrenal tumor, and excess production, which is very rare. So most of your cases will be incomplete in this regards or central idiopathic. Peripheral will be very less likely. So now I invite Dr. Vibha to cover about the different aspects of etiology of precocious puberty.
I think this kind of physiological variant of the appearance of the pubic hair just slightly earlier. It's typically presented during the age of 6 to 8 years, and it is commonly seen in SGA girls. So, present with the variable clinical features, the DHL levels could be normal or slightly elevated. This could be the first sign of the insulin resistance in the with girls with SGA. And the courses, it is usually self-limited, no hesitation is required here. But we should be very careful. And be vigilant about the virilizing features to rule out the CH or the rarely adrenal tumors. It has a wide spectrum. It could start from the pubarchy, where the DHS levels are normal, and the bone age height is normal, whereas in the adrenarchy, the DHS levels are slightly elevated, and the extreme case is the exaggerated adrenarchy, where the DHS level is very high and bone age is very advanced. Coming to the premature pubarchy, here the appearance of the pubic hair is slightly earlier. The growth is normal, the bone age is also normal, and both the DHEAs and the testosterone levels are in the pubertal range. Here also, it is this condition is self-limited, and we have to observe the patient very carefully. In the premature adrenarchy, there is a slightly increase in the growth. The patient is slightly taller. The bone is slightly advanced, but it is not that much advanced that it will compromise the final height. The DHES level and the testosterone level are in the pubertal range, that is 40 to 130 microgram DHES and 20 to 35 nanogram DL, the testosterone. Generally, these cases are self-limited and do not require any treatment. But the girls with SGA and those who got the precocious puberty, precocious adrenarchy, they could be the forerunner for the development of PCOS, fatty liver, type 2 diabetes, and etc. The exaggerated adrenarchy is the slightly it is the pathological form, and we have to very carefully evaluate these cases. These cases present with the increased growth. The girls are taller and the bone age is advanced, which will compromise their final height. The DHES level is more than 130 and the testosterone level is highly raised, that is more than 35 nanogram per DL. They are progressive and they have to be evaluated every cause. We have to rule out the CH, we have to rule out the virilizing form of the adrenal tumors. So we have to be very vigilant in these cases who presented taller. Now, if we see there are pubic hairs before the 6 years of age, we are really worried. But there is a physiological variant, that is the pubic hair in infancy, and it presents generally between the 6 to 12 months of age. And generally the pubic hair, the hairs, I'll not say pubic hairs, are present in the labial regions, which are vellus, very soft, and they are not actually present in the pubic hair, and there is no clitoromegaly. The workup is not required in these cases, but some can do workup just to rule out the pathological causes. In these cases, the DHES and the 17-OHP is normal. And we should reassure the patient that it is just a physiological variant. Now, coming to another incomplete variant of precocious puberty, that is the isolated vaginal bleeding. Here, the patient will present with only vaginal bleeding. There will be no telarchy. And in these cases, all LH, FSH, and estradiol are very low. And we should exclude trauma, history of trauma, tumor, infection, and abuse. And in these cases, local examination by the gynecologist is must. And we should then we have to follow up these cases for further pathological causes. Now, coming to the isolated telarchy of infancy,
This usually presents between 1 to 3 years of age, and among them, 20% of them are progressive. The most important thing here is to look for the LH level, because in this case, LH is normal, and the FSH is usually high at the age of 1 to 3 years. So high FSH we should not be worried about. On the USG, we'll get the microcystic ovary, which is due to the high level of FSH, and they are generally self-limited. And we have to reassure the parents that they will regress by 5 years of age. We should follow up the patient annually or 2 yearly, and after that, after the age of 5 years, they do not need any follow-up. This is isolated thelarchy of childhood is a separate entity. Generally, it is more likely of a slowly progressive puberty, typically presents between the age of 6 to 8 years, and 30% of them are progressive. They'll also have normal LH and high FSH levels with the microcystic ovary. These patients, this condition is generally associated with obesity. It is self-limited, does not require any GnRH analogs, so weight reduction is must, and we have to counsel the parents that with the weight reduction, they'll progress, the thelarchy will not progress. Now coming to the most common cause of precocious puberty in girls, that is the idiopathic cause. Here it is it tends to be autosomal dominant, sex dependent, and the studies have shown that the obesity, change in the environmental factors have a great impact on the onset of puberty. Coming to the slowly progressive puberty, it is generally present between the age of 6 to 8 years, and the patient will present with mild growth acceleration. Their bone age will not be advanced. The growth velocity is less than 6 centimeter per year, and the bone age will be normal. And what I mean by normal bone age, that height standard deviation for bone age will be less than -2 standard deviation. And they do not require any active intervention. We have to follow up these cases because some of the cases can turn up to be rapidly progressive. So we have to be vigilant in these cases. And there is no role of any GnRH analog. So if we compare the slowly progressive puberty with the rapidly progressive can occur at any age group, but the slowly progressive usually occur after the 6 years of age. And if the patient present with the rapid progression of the breast stage from 2 to 3 to 4, and there is advanced height, the bone age is advanced, the basal LH is above 0.3, endometrium thickness is above 3 mm, uterine size is more than 34 mm, and the uterine volume is more than 2 mm, then these are the pointers for the rapidly progressive puberty, and we should evaluate these cases very carefully. Coming to the second common cause of the central precocious puberty, that is the hypothalamic hematoma. It is basically a migrational defect. Here the normal hypothalamic tissues is present in the abnormal area that causes the central precocious puberty, and they present very early, like in the 1 to 2 years of age, and they have a rapid progression. The progression is so rapid that they present with the early menarche just after the onset of thelarchy, and they are associated with gelastic seizure. So if anyone presents like this, always be careful to take the history of gelastic seizures, that is the laughing spells. And they are managed by GnRH analog. Due to the very high level of LH, high dose of GnRH is required in these cases. And surgery is not required, even because the surgery will not change the pathology. It will not help in the stopping the progression of the puberty. So surgery is not required in these cases. Coming to the another cause, that is the malformation. And we can have hydrocephalus. In the hydrocephalus, there is an increased intracranial pressure that disrupts the inhibitory pathways, which causes the onset of puberty, and it is very early in onset. But when it is reversible, when the intracranial pressure reduces, then this will come back to normal. In the arachnoid cyst also, there is an onset of puberty due to the raised intracranial tension, and it has a later presentation as compared to the hydrocephalus. In the dysgenesis, here, with the increase in the vaginal bleeding, there is an increased seizures frequency, and the patient have intellectual delay in case of dysgenesis. The pituitary adenoma, we all know that pituitary adenoma, if this is a LH, if it is any gonadotropin secreting pituitary adenoma, then there will be the continuous secretion of the gonadotropins, which will desensitize the gonadotropins. So it is very rare to say that there is a pituitary adenoma is the cause of precocious puberty. But if we get the precocious puberty and there is a pituitary adenoma in the MRI imaging, that this is usually an incidental finding. It is generally not due to the pituitary adenoma. It is due to the increased ICG, increased intracranial pressure that has raised to the precocious puberty. We manage this case as per as the size of the adenoma, whether it is micro or macro adenoma, and we do the workup for the evaluation of anterior pituitary hormones. The MKRN, it is, as sir has already described, it is the inhibitory, it inhibits the onset of puberty and DLK1 also. So when there is a defect in the MKRN gene, it causes precocious puberty. Basically, it is present in the Prader-Willi region, and it is a maternally imprinted inheritance. And it presented, it is due to the early inactivation of the inhibitory signals. So that causes the onset is generally in the childhood age group, and it has a very slower progression. And as I already mentioned that it is a maternally imprinting inheritance. It is due to the paternal defect, and it is associated with esotropia, clinodictyly, and dental defects. Now coming to the radiation, as a radiation can cause both precocious and delayed puberty. With a low dose of radiation, that is 12 to 30 grays, it disrupts the inhibitory pathway and causes precocious puberty, while when there is a high dose of radiation that is more than 30 gray, it damages the puberty and causes the delay. It damages the pituitary and causes the delayed puberty. And it is also associated with a growth hormone deficiency. Now coming to the peripheral precocious puberty, and one of the common causes, the functional ovarian cyst. The patient presents with a very fluctuating course. This onset of thelaki is not concordant with the vaginal bleeding. The investigation will show high FSH that has leads to the formation of ovarian cysts. The estradiol and the testosterone levels will also be high in these cases, and the patient will say that the size of the breast is reduced after the vaginal bleeding. So it should be clearly asked when the patient comes to us with these features that what happens to the size of the thelaki after the bleeding. We have to observe these patients, and surgery is required when there is a torsion or when the size of the functional ovarian cyst is more than 8 centimeter. Coming to the granulosa cell tumor, it is the rare cause, and it is the estrogen producing tumor. They have a very rapid progression and a very high estradiol level and low FSH level, and they have high HCG, inhibin, EMH levels. And the management is generally surgery in these cases, and we have to monitor the patient after surgery. Coming to the interesting cause, that is the McCune-Albright syndrome, where there is a activation of the FSH and the LH receptor. They both act to the GNS pathway. Here, the patient will present with the thelaki. They will have vaginal bleeding, but there will be no pubarchy. And on the ultrasound, they will have a very large ovarian cyst. So, because we know that there is on the extent of it is basically a somatic mutation. So depending on the extent of the somatic mutation, depending on the spread of somatic mutation, the patient can have thyrotoxicosis, they can have GI excess, they can have Cushing-like syndrome, they can have cafe au lait spots that are large and regular in shape, and they can also present with hypophosphatemic rickets. So they have a fluctuating course, and they can also lead to the secondary central precocity. This is mainly due to the defect in the R201H defect. 50% of them is the germline mutation, and 90% of them is due to somatic mutation. Now coming to the hypothyroidism, as sir has said that FSH and TSH has a functional homology due to the similar alpha subunit. So when in hypothyroidism, there is an increase in the TSH this increased TSH will act on the FSH receptor in the ovary, and that will lead to the formation of ovarian cyst. and the patient will present with telarchy. They will have vaginal bleeding, but their bone age will be retarded because they have their gonadotropin levels is low. We know that the increase in the TSH level rise to the TRH, and TRH is also stimulant for the prolactin levels. So in this case, the prolactin levels are high and they suppress the gonadotropin, that is the LH. And due to the suppression of gonadotropins, there is the LH will not act on the adrenals and there will be no pubarchy in these cases. So these are the common causes of the precocious, of the central as well as the peripheral precocious puberty. And now we'll go on to the management of this. Thank you.
Thank you, Vibha, for this nice discussion about theology and making my life easy from that perspective. We'll see if there are any particular questions which are there at this point of time before going ahead. We'll progress in terms of the overall management, which becomes very, very important in terms of assessment, and how do we treat, when to treat, what preparations to use in that perspective. So if we now go ahead in terms of the management of precocious puberty, the key questions which we have to answer in terms of precocious puberty management is whether it is really a precocious puberty. If it's a precocious puberty, is it complete or incomplete? And then finally, it's central or peripheral precocious puberty from that perspective. And how do we manage that particular condition? So first of all, in terms of precocious puberty, we know that if there is any pubic hair development or breast development, that could be a sign of pubertal development or vaginal bleeding. But in certain scenarios, we may not get it, and often parents do not really get these points, and we may get referral for rapid height gain, change in odor, and acne, which may be the manifestations in this perspective. Precocious puberty in girls, of course, is defined as onset of pubarchy or thelarchy before 8 years of age, which is 2.5 standard deviation score before, or vaginal bleeding before 9.5 years of age. Now, what we also need to remember is that if somebody comes to you at 8.5 years with breast stage 3 or 4, it doesn't mean that you will say that, okay, this is not precocious puberty. We're talking about onset of puberty. So onset may have happened earlier. That's why they've gone into B3. So anybody who is B3 and above, even beyond 8 years, you have to start worrying about. So you need to understand the dynamics of pubertal development as to see whether this level of development is appropriate for the age or not. So of course, breast development is most important. There are certain mimics which are common, particularly neonatal thelarchy, which is there, which is commonly because of the transplacental passage of estrogen. Lipomastia, which is a physiological phenomena, and finally, which Vibha talked about, is the pubic hair of infancy, which is actually the labial, 1 or 2 single labial hairs which are present. These conditions do not require evaluation or management. Now, assessment of pubertal status, one would say estrogen is the best marker. But if you look at the second case I talked about, estrogen, particularly done via the routine chemiluminescence assay, is not a good marker of estrogen status in the body. So that's not very good. You have to think about vaginal mucosa. So all you want to do is to inspect the vaginal mucosa, ask the girl to spread the thighs and see exactly whether it's red, which is basically meaning no estrogen, and pale, meaning estrogen exposure is there. Endometrial thickness more than 2 mm means that there is some development. More than 5 mm mean that you're going to very close to menarche. Rapid growth and bone age acceleration is again another pointer as far as precocious puberty is concerned. And sometimes you can get history of vaginal discharge or abdominal pain, which means that you're very close to menarche in that perspective. So as I said, estradiol role is more for confirmatory purposes, but if you have low estrogen, it does not exclude precocious puberty, because then it may not be a very good tool in that perspective. However, if the levels are very, very high, more than 100, we are talking about peripheral precocious puberty in that scenario. The problem, of course, as I said, is that chemiluminescence assays may not be very good marker of estrogen status. And in that scenario, you have to be careful in that perspective. Ultrasound is a very, very important parameter. So if you have a girl with precocious puberty, besides your pubertal assessment, besides your growth chart, you will get a bone age, ultrasound, as well as the LHFSH estradiol. So if you have a length which is above 32 mm, volume of uterus more than 2 ml, and endometrial thickness above 2 mm, you start thinking that the girl has entered into puberty. Now, whether this is progressive or non-progressive, that is the second question, which Vibha had already mentioned in that regards. Shape often may be a very good marker. So if you see this sort of uterus, which is a pear-shaped, where the cervico-corpal ratio is more than 1, rather than a tubular structure where your cervix and corpus both are the same size, this is more likely to be a pubertal uterus in that regards. Bone age is extremely important because it will give you a clue. It will confirm precocious puberty. If it's delayed, you're thinking of hypothyroidism as a possibility. It will also give you a clue about the height prognosis, because ultimately height is the most important parameter which we like to follow up in that regards. So you can look at parameters like bone age to chronological age difference, bone age and height age, as to how much is the height bone age compared to the height age. Or I would say a more important word will be a height standard deviation score for bone age or predicted adult height in that regards. One is concerned if the bone age is above 120% of height age, and it will also give you information about height prediction. If your height SDS for bone age is less than -2, that also is a cause of concern, and the need for treatment may happen, as we'll discuss subsequently. Once you know this is precocious puberty, you want to know whether it's complete or partial. If you have just the breast development, this may be the first sign of progressive puberty. However, if you only have pubic hair development, you have to think about congenital adrenal hyperplasia or adrenal tumor. If you have isolated vaginal bleeding, this is not an endocrine cause. We're talking about trauma, tumor, or abuse in this perspective. So if there is just thelarchy, you need to really work up for bone age, LH, FSH, and ultrasound. If it's pubarchy, you may need to do workup for DHEAS, followed by workup for CAH in that regards. If there's vaginal bleeding, of course, in that scenario, you have to refer basically for a gynecological referral, because this is the local cause in that regards. Now, isolated thelarchy is a common presentation, especially in younger girls. And in that scenario, if you have a normal growth, low level of LH, normal bone age, and estrogen, which is puberty appropriate, you do not need to really worry. On the other hand, if you have a high LH, advanced growth, advanced bone age, you can think of progressive puberty, which is happening in that regards. Very importantly, we can have microcystic appearance, which may be noted in the scenario of isolated thelarchy, which is not a pathological variation in that regards. Isolated pubarchy, already Dr. Vibha has talked about the 3 variants. One is the idiopathic one, which is isolated, the adenarchy, or the exaggerated adenarchy. I'm mainly concerned in the exaggerated adenarchy section. So if a girl has a pubic hair stage which is 3 and above, if the height is increased, the bone age is advanced, the DHEAS level is above 130, and testosterone is more than 35, the likelihood of a pathology becomes significant, and then you will need to do some evaluation and management in the form of 17-OHP and imaging in that regards. Now, the next question is central versus peripheral. So if you have a chaotic scenario, a rapid progression, in that scenario, think of a peripheral precocious puberty rather than central. And here your LH and FSH levels will give you a clue. So if your LH is more than 0.2, this is more likely to be a central. Less than 0.1 is clearly peripheral from that regards. And in certain scenarios, you may look into GNRS testing also in that scenario to classify from that regards. Remember, in younger people, we can tolerate higher level of LH because of the persistent mini puberty, which may be there particularly during the infantile period in that regards. Now, once we know that this is central or peripheral, the next issue is what is the cause. So clinical pointers become very important. If you have onset in the first 2 years of life, this is either a hypothalamic hematoma or a McCune-Albright syndrome. If you have CNS features like headache, vomiting, think of organic cause. Look for cafe au lait spots. If you have regular cafe au lait spots, this could be neurofibromatosis with a optic nerve glioma. If you have irregular cafe au lait spots, this is suggestive of McCune-Albright syndrome as a possibility. Growth should be accelerated in everybody who has precocious puberty. Short stature with precocious puberty, think of hypothyroidism. If there is family history, think of some of those genetic causes. And again, absent pubarchy, as I said, is more likely to be peripheral in origin, particularly hypothyroidism in that regards. So already discussed that if you have only pubic hair development, this is adenarche. If you have no breast, no pubic hair, only bleeding, this is a local cause. If you have breast development but no pubic hair development, this is likely hypothyroidism or a peripheral cause, while in a central cause, you will have both breast and pubic hair development, which will happen in that regards. So your gonadotropin levels will give you a clue, and really you may need a GnRH analog. If you have pubertal LH, then if a girl is less than 6 years of age, that is the time when you should get an MRI done. Otherwise, you don't need to do an MRI because the likelihood of a pathological cause being identified is very less after 6 years of age. If your prepubertal LH, go for a focal imaging in terms of ovary and adrenal ultrasound. Very importantly, bone age and thyroid are very, very important from that perspective. So first of all, look at the extent. If it's only pubarche, look at DHEAS levels. If the DHEA is less than 40, this is pubarche. 40 to 135 is adenarche, and more than 135, you need to evaluate for adrenal pathology in that perspective. And then you can decide whether you need a evaluation for CAH. If it's just a vaginal bleeding, look for local cause. If, however, it's complete or isolated thelarche, look at bone age. If bone age is delayed bone age with precocious puberty, think of hypothyroidism. If it's normal, this could be a slowly progressive puberty, while if it's advanced, get a LH level done. LH is prepubertal, think of a ovarian cyst as a possibility. If it's pubertal, think of a central precocious puberty and an MRI. So essentially look at the pubic hair and a breast development, and then go ahead with gonadotropins to get the result in that regard. So this case I've already discussed, that never unnecessarily work up a case of precocious puberty unless you've excluded lipomastia. So you palpate your breast, the areola area using your thumb and finger, approximate it. Only if there is a resistance, do evaluation. Otherwise, you will have a significant anomaly. The second case of this low estrogen, in which it was said that, okay, this is not precocious puberty, again gives you a message that look at the vaginal mucosa. If vaginal mucosa is pale, this suggests that this is clearly a estrogen exposure, and this estrogen levels may not be very reliable. So now we have a 2-year-old girl with thelarche, Dhwani, who presented with onset 6 months ago. It doesn't look like very progressive. She has stage 3 breast development. What do you think is happening here?
6 months. So, arrhythmia has a functional cyst. It could have flared and biggest fibrosis.
Yeah. Yes, so this age of onset looks more likely to be isolated thelarche, and in this regards, LH is undetectable, FSH is 3.2. So what do you think? Your diagnosis is correct then? Yes, so we need to follow them up, and ultrasound shows a very, very small cyst, which is a microcystic appearance, which Vibha said is common in this scenario. 1.8-year-old girl with thelarche, Alapan, onset 6 months ago, which is progressive. She has stage 3 breast development. Is she the same as the previous girl? And it's breast 3, which again becomes very, very significant. Yeah. And the onset is much earlier than the earlier girl. So now your workup shows a LH, which is 0.61, FSH is 3.2. What will you do? Would you like to do an MRI here? So you have to be very, very cautious in this regards. But as I said, your LH may be slightly high in the first 2 years. So don't be too aggressive here in this case. So ultrasound showed a ET which was less than 2 mm. Your MRI was done, which was normal. I might have even avoided MRI also in this scenario, because if you have hematoma, frankly speaking, in 6 months, it will be so rapid that this will result in a scenario of a clear-cut scenario of bleeding, which would have happened in this regard. So better to observe in this regard. So don't do unnecessary workup also in that regards. Now, Vibha, 2-year-old girl with vaginal bleeding, thelarche 3 months ago, recent onset thelarche. She is reasonable in terms of height. There is no pubic hair development. There is stage 3 breast development. What are you thinking of? Hmm.
this it would be due to functional ovarian cyst.
But usually functional ovarian cyst B3 becomes less likely and the history is 3 months. So ovarian cysts usually go off earlier. So this could be McCune Albright. This could also be a possibility of a hematoma. Because in hematoma, what happens is that you have too much estrogen. So that behaves like a pseudo peripheral precocious puberty. You don't have that much time for breast to grow. So these possibilities in a very young child you have to consider. So bone age was very, very advanced. And further workup showed LH epithet which is suppressed. So this is more likely to be now a peripheral precocious puberty, as you said. And ultrasound showed ovarian cyst. So here you may have to think of a McCune Albright. There will be cafe au lait spots or fractures or rickets, which may give you a clue. 1.5-year-old girl with menarche, dhwani, and breast stage 2, pubic hair 1. So what do you think?
Your central is slightly less likely, but central and peripheral both should
Yeah.
be considered.
But with breast 2, we would be making it less likely. So anyway, you will get the reports. She is height is 86 and your LH is 3.4, FSH is 1.8. So if you remember Alapan's case, the LH was 0.6. The previous case which we talk about isolated thelarche, LH was undetectable. So this is significant. So if you have this sort of a level, this means so organic pathology becomes likely. So high LH means organic pathology and you need to do a MRI in this regards. So you will have a hypothalamic hematoma. So the big message is don't get confused with this B2 and menarche. So all this talk we talk about that, okay, you need to have a proper concordant development and this is central, this is peripheral, may not be valid for somebody who is only 1.5 years. She didn't get time. So her hematoma is causing so much LH to be produced, estrogen is high, and that's why she is not having time for breast to grow and she has bleeding. So this is an important message from that regards. 1-year-old girl with pubarche, onset 3 months ago, slowly progressive. On examination, she has couple of hairs. Mother is really concerned. Do you think she requires workup for hyperandrogenism and virilization? So this is what we say, isolated pubic hair of infancy do not require much evaluation. If you do DHEAS will be very, very low in that perspective. 7.5-year-old girl with pubarche. So this is a different scenario. Birth weight was low. She was SGA. She is reasonably okay in terms of height, maybe a bit tall. Pubic hair stage 3 and B1. So stage 3 we start worrying. Now you did workup, you found DHEAS of 110 and testo of 25. So which of these 3 categories, pubarche, adenarche, exaggerated adenarche, you will keep? So this is simple adenarche. And we have discussed that in prematurity, especially SGA babies, premature pubarche may be a marker of insulin resistance. So this does not require immediate treatment, but we need to be following up very strictly about lifestyle manifestations and weight should not gain more in this scenario. So what medication sometimes we can use in this scenario? Yes. So we should look for, because she would probably be around the obese category by this or overweight category, we should get the blood sugars, SGPT, lipid profile. And if there is evidence of insulin resistance, we may think of metformin as a possibility in this scenario. So bone age is not that advanced. So this is a classical case of adenarche. The first one was isolated pubic hair of infancy. This is adenarche. Now next case, 26-year-old girl with pubarche. Birth weight was normal. She is tall, taller than the previous child, non-obese. Weight is 26 kgs. She has stage 3 development again. Now compare this to the previous girl. Do you think there are some differences here? And earlier onset. So that was 7.5. So this goes more in favor of a pathological cause. So here we found DHEA with very, very high. Testo is high. So the most common likelihood possibility will be not virilizing, because virilizing CH basically means you will have clitoromegaly, you will have labioscrotal fusion. So non-classical CH as a possibility will be there. So 70 bone age was also advanced and 17 OHP was elevated, which suggested a non-classical CAH, which becomes important. Okay, 7-year-old girl with vaginal bleeding, Alapan, one episode, B1, P1, and there was one episode of bleeding. What do you think here? Will you do an MRI here?
Isolated local cause.
Yeah. So vaginal mucosa also did not show there is local extrusion. So this is a non-endocrine cause of bleeding. LH is low. So here you should definitely go ahead and refer a gynecology referral. And this was found to be foreign body. So again, a message, if you have isolated vaginal bleeding, this is clearly a scenario in which you have a cause for gynecological evaluation. 6.5-year-old girl with menarche, last 1 week only she had thelarche. So this is there. Mother is very clear there is no long-term breast development. Last year she noticed some breast development and now she has bleeding. What do you think? What is this suggesting?
Presentation that the breast development will regress for the onset of bleeding. So this is the case of functional guidance.
So this is classically that something produced too much estrogen. That estrogen caused temporary breast development. And what is causing bleeding here? High estrogen withdrawal. So once the estrogen fall, then your uterus endometrium is not being sustained, and then you will have a bleeding which happens. So she is not tall, she has no pubic hair, breast is stage 2, and in this regard, this is a ovarian cyst which is there. You do not need to do much unless it's a large ovarian cyst, then only surgery is indicated in that regards. 7-year-old girl with thelarche. This I think I'll put to Ashutosh. So this is a girl who presented to us with thelarche for the last 3 months. Her height is 100. So this 7-year 100 is short, tall, normal. So 100 centimeters at 7 years is very, very short. And she has thelarche. She also has vaginal bleeding. She has no pubic hair. She has stage 3 breast development. So what do you think is causing precocious puberty in this short girl? So every girl with precocious puberty should be tall or short? Tall. So if you are short, you think of thyroid. And you found that she is short, she has delayed bone age, she has large ovarian cyst. This is the classical von Wieck-Grumbach syndrome. And what is causing this precocious puberty in this girl? So TSH is acting on the FSH receptor causing precocious puberty. So clearly this is a case of hypothyroidism causing precocious puberty. TSH is very high. Don't do anything, just correct thyroid and you will get a good response in that regard. Quickly about management. So the options of course are that we will have to basically treat with central precocious puberty. If there is an early onset, the main reason for treatment is for height. So onset below 6 years, 6 to 8 years with advanced bone age, you will need treatment in that regard. You give GnRH analog, which causes continuous exposure, resulting in desensitization in that regard. So this is the continuous one, which improves with that. Remember that every time you give a GnRH analog, you will cause some flare effect. If you already have a good control, this flare will not cause a lot of problems. But if you have inadequate control, the flare will again cause an issue. So this should be given every 12 weeks on the dot. Adherence becomes very, very important in that regards. You will have regression of breast development, stoppage of periods, and the growth will become slower. Pubic hair, of course, will not be affected in that regards. This is important to remember. You can use medroxyprogesterone in somebody who is intellectually challenged, where height is not an issue. You can give progesterone to delay menarche, particularly with no effect on height in that regards. So if the onset is below 6 years, you have to treat. Above 8 years, no treatment. 6 to 8 years, if you have a progressive puberty, your bone age is advanced, your uterus is advanced, then you treat. Otherwise, you don't treat in that regards. And this becomes important to remember. And this is a major question because most girls who come to us between 6 to 8 years of age. And there you have to decide whether GnRH analog is given or not. And that will depend upon your bone age and ultrasound, which will give you a clue. GnRH analogs basically have alteration in the structure of GnRH to allow a longer effect. Most of us are using leuprolide. The dose is 3.75 milligrams every 4 weeks or 11.25 every 12 weeks. There is not much of a difference. Younger girls, which Vibha said with organic pathology, may need a higher dose. Girls who are presenting with menarche or very close to menarche may benefit initially with a 3.75 monthly because the flare will be less, and then you can go for 11.25 in that perspective. There's also an annual one which is available. So we mostly will be using leuprolide, usually 12 weekly preparation. In somebody where the control is not very good, you may be thinking of a possibility of 22.5 as an injection in that perspective. The options as far as the peripheral precocity is concerned, which again is an important issue, is the use of agents which decrease either the estrogen production or the estrogen action. So in peripheral precocious puberty like McCune-Albright, you may be using a scenario wherein you are inhibiting the estrogen production using aromatase inhibitor or selective estrogen receptor modulator like tamoxifen, which will alter the effect of estrogen in that regards. If you have hypothyroidism, you give them thyroid and they will have an improvement in that regards. One can also use a estrogen receptor antagonist, which is fulvestrant, which will also result in improvement in terms of this scenario. So McCune-Albright, the options are aromatase inhibitors, selective estrogen receptor modulators, or estrogen receptor antagonist. For functional ovarian cyst, generally surgery is required only in large cyst with polycystic area and the risk for rupture and torsion. So we have tried to cover a lot about precocious puberty in terms of the last 1 hour, in terms of evaluation, etiology, and management. Now we have got Dr. Alappan, who has got some quick quiz, which is there, which we'll be able to get it from that regard. So Alappan, you can start off. And Dhwani is our quiz master, who will have a look at the answers and see what is happening from that regard. And who is answering that?
Thank you, sir. Good afternoon, everyone. So the topic pediatric, the precocious puberty in girls is very important in terms of pediatric residency. And I think all the pertinent points have been covered well by sir and ma'am. So I'll hope everyone will get to answer every question I'll put in front. So this first case, 8-year, 9-month-old girl child presented with recent breast development. We have examined, the pediatrician has examined and he had seen a breast development B2 and P1. And he was advised GnRH analog by our pediatrician. So what is your opinion regarding this?
Do you think this girl requires treatment? 8-year, 9-month-old girl, B2, P1. What is required, Abhishek, here? Before you decide treatment? Bone-in, uterine size, LHFSH. Generally, beyond 8-year onset, we don't talk about treatment. Any answers? So all of you are encouraged to write on the Q&A for the answers.
So generally, when we say about precocious puberty in girls, it is usually before 8 years of onset. The onset is before 8 years, and the following investigations that LH, FSH, is bonus are absolutely normal in this child. So probably this is a normal pubertal development that has happened to the child, and the parents were much concerned about this thing. So definition of precocious puberty has been already described by sir. So the next case.
So what is the definition?
Definition is if the breast development or the puberty is before 8 years in female child, and menarche is before 9.5 years in case of female. So next case, the 5-year-old girl child, she has also concern about the breast development and advised about the GnRH analog. And we have seen the child. The child is a obese one with BMI of around 23.4 kilogram per meter square. So we examined the child and there was no breast tissue on palpation. So the diagnosis.
So what is the diagnosis of this obese girl who actually has no breast tissue on palpation? So I think this is what we discussed a lot. That we are seeing a lot of obese girls who come to us with just increased breast. Now obesity can cause precocious puberty because of peripheral conversion, because of trigger of bone age, but whether it is required or not. So this is the case of any answer.
Is not visible. उसको क्या करते हैं?
Mouse is not moving much.
Okay, so we encourage all of you to put in the chat box with the option. Yeah, carry on.
So the next case, 12-month-old girl presented to us for the breast development for the last 1 month. Yes, the child is not so sad as was seen in this picture, but the parents were concerned about this breast development, and he had come to us for the opinion. The length of the child, we examined the child and seen that length is appropriate for 1 year of age, and the bone age is around 1 year of age. We have also gone for the LH and FSH somehow, and the LH level was 0.1, less than 0.1, and FSH was a bit higher in 4 milliinternally.
12-month-old girl with a high FSH.
Yes.
So do you think this is central to process puberty? Okay, so high FSH, which is more important, LH or FSH? So there's some answer which is coming up. You can't see that. So it's because of the high LH level. Then only we'll be concerned. This is a classical case of isolated hierarchy for which no workup is required. So who has given the answer correctly, Dr. Alappa?
So answer, the chat box is disabled. Someone.
Okay, so you can put in the Q&A as well. We will try to enable the chat box. So you can answer on the Q&A section also already. We don't know why it is working like that. So the next question. So this is isolated hierarchy of infancy. Yeah, carry on.
So the next case, 8-year-old girl presented with unilateral breast development for the last 3 months. Again, the parents were anxious. They went to near pediatrician, and she advised that the child requires an biopsy and USG in concern of the breast CA. So do you agree with this diagnosis of breast CA in this child? And do you recommend unnecessary these treatments in this child?
So how common is breast carcinoma in girls at this age?
It's likely, so CA becomes very unlikely.
It's unlikely. It's not there basically because it's mainly a estrogen dependent tumor essentially. So this, what do you think we should be done in this case?
Pediatric can start in one, like it can be unilateral to start with. So careful follow-up is what is required.
30% girls will have bilateral. There will be asymmetry which is there. So let's see who has given the right answer here.
Yes, Dr. Salem has given it could start unilaterally. So no need to investigation, common at onset of therapy. Yes, this is a normal pubertal development. The treatment is usually not required, and unnecessary investigations are also unnecessary in this case. So the next case is a 11-month-old girl child, and she has concern regarding the breast development for the last 3 months. We examined the child and seen that he has a pretty tall height, standard deviation score of 1.71 with SMA staging of B3, P1 and M0. So what could be the investigation that is planned after this case?
This is less than 6 years of age, a tall girl with stage 3 breast development. So do you think this is a slowly progressive or a rapidly progressive?
I think if the breast staging is 3 at age of 5 years, 11 months, that it has been started long before. So I think.
So this is clearly a rapidly progressive one. So what workup would you like to do? She's a tall girl, so of course we have to work up for precocious
puberty. And the LH, FSH, LH level was pretty higher, 0.75, and bone age was pretty advanced, around 10 years of age. So the question is whether this child requires imaging or not in this scenario.
What do you think, Vibha? So less than 6 years, you may be thinking of MRI as a possibility.
So again, the next case, a similar case, but this time this 5-year, 11-month girl child has presented 3 months back of breast development. Height is similar with similar breast staging, but here LH is around 0.1 with estradiol is high and bone age is higher. So any investigation further we need to do before confirming this is a case of central precocious
So you
puberty.
have a girl who earlier had a baseline LH, which was in the pubertal range, and this is a baseline LH in the prepubertal.
Pubertal
So
range.
what's the most common cause of precocious puberty in the central versus peripheral? So what's the most common cause of precocious puberty with high LH? Central? What is the most common cause of precocious puberty with low LH?
Peripheral.
Central.
Achha,
So
oh,
if
that
you
is
do a
why.
GNRS stimulation test, in that scenario, it will be the central. Because peripheral is extremely uncommon, unless you have some other features of course. Because the way you have described, she's pretty tall and she has a reasonable breast development. So clearly this could be mostly. So before you rush to a central or peripheral cause, do a GNRS stimulation test here, unless of course you have cafe or spots or other parameters. As I always say, the most common cause of thyrotoxicosis with eye signs is
Grapes.
without eye signs is
Grapes,
also
grapes.
grapes. Without goiter is also grapes. Because that's so much common. So ideally you should do a GNRH test unless there are other parameters. So what did you suggest here?
Sir, GNRH stimulation study
Yes.
could be done in this case, and the post-decapeptide level it was around 6. That confirms this case is a central precocious puberty. So the next case, a 6-year, 5-month-old girl child presented with isolated pubic hair development with no breast development. She was a term child with birth weight of 2.2 kg. SMR staging we have done seen that pubic hair stage 2 and bone age around 7.8 years. All the investigation of precocious puberty has been done and it was normal. So
Why was the estrogen done in this case? When there is no breast development?
estrogen should not be done in this case actually.
Even LHF is not required. So you should have done, as if you go by our algorithm, you should have do the DHAS level if at all. So what do you think? This is exaggerated adenopathy? This is isolated adenopathy? Clinically, what do you think?
No, sir, it's not exaggerated.
It could mostly be a
Isolated as
adenopathy,
a-
simple premature adenopathy. Bone age is mildly elevated. So you can do the basic DHEA and go from there. Any answers if you can look at it?
Yeah, answer. Okay, so the most important thing, sir, the birth weight was, the child was SGA, so probably rapid catch-up would provide.
So this is the classical case of premature puberty, in which you have a SGA with rapid catch-up, which is causing this.
So any future risk in this case?
So people can write what could be the possibility here. This is the SGA girl who has a rapid catch-up, and precocious puberty may be the first sign of insulin resistance. So there is a risk of developing PCOS hyperandrogenism. So people are mentioning that. So hyperandrogenism, type 2 diabetes, insulin resistance, they all can happen. Carry on.
Okay. So next case, a 9-year-old girl child presented with vaginal bleeding. He has a SMS staging of B5, P1 and M1. So investigation in terms of done and has seen that a low LH and FSH level with a high estradiol level with a bone age of around 7.5 years. So before jumping into any other investigation, what is the first investigation that should be done in this case?
I think this is a very classical case which we have always emphasized a lot. A girl who has vaginal bleeding without pubic hair development, who is short. The most common cause is hypothyroidism. So we should do a TSH level in that perspective.
So
I think people have answered also. We can mention who is
TSH
anonymous. Attendee has given TSH as a possibility. No need to be anonymous in that. So of course this is hypothyroidism clearly, which is there. Carry forward.
So the next case is a 4-year-old girl child presented with vaginal bleeding. He has a SMS staging of B3, P1 and M1 with multiple cafe alveolar spot. Also, there are some bony changes present in the X-ray. So the diagnosis is clear from
I think this is very, very clear. You have got very, very early onset with no pubic hair and multiple cafe au lait spots. Now, the only thing is that there are two conditions in
That
which you can
present.
have cafe au lait spots with precocious puberty. Only one of them will have bony deformities. The other one will have more of a cutaneous
Manifestation,
lesions,
yes.
like you will have neurofibromatosis. So this is more likely to be macunal, right? And you will have irregular cafe au lait spots. So I'm sure people would have been able to pick up the MAS as a possibility. Dr. Ekta again is there, and NF as a possibility already given. But bone changes are there, which means fibrous dysplasia is more likely to be a case of
Macunal bad
macunal.
interest.
Carry on, Dr.
So the next few sentence I will tell, and you have to tell whether it is a right or wrong. The first question is first statement is the most girls with precocious puberty have no underlying cause. Just you have to write true or false.
So you can say yes, no, why, and
Y or N. True.
so most
So
are saying
of them-
true, so it's going fine. I think everybody is agreeing. 95% do not have a pathological
Pathological
cause. Carry on.
Second, discordant pubertal development suggests central precocious puberty.
So discordant pubertal development means that you have got vaginal bleeding within 1 year of period. So Dr. Ekta, Anonymous, Secondly, Salem, Dr. Mehta have all said no. So this is also, again, I think the message has gone through well.
Yes, the next is bone age is usually delayed in precocious puberty.
So I think this is a very, very clear cut issue. Bone age is usually not delayed in precocious puberty. I think a lot of people are again very, very clear about that. So this is there. Carry on.
Next is the thelarchy is the first sign of puberty.
So let's wait for people to come on. Thelarchy is the first sign of puberty. Now, if you say thelarchy is always the first sign of puberty, or thelarchy is usually the first sign of puberty, your
Usually.
statement needs to be classified. So, if you say thelarchy is the first sign of puberty, it is incorrect. But if you say it is usually the first sign, 85%, this is clearly correct. So, usually, yes.
This
Dr.
is-
Mehta
this
has
should
said
be
usually,
usually. Yes, yes.
which is a very right answer.
Next is the treatment of choice in central precocious puberty, GnRH analog.
Yes, so I think we've discussed about this. Why don't we use GnRH antagonists instead of analogs?
Antagonist,
So what will be the benefit of a GnRH antagonist?
benefit will be, there will be absolute suppression of the.
There will be no flare.
No flare
response.
of response.
But the problem with GnRH antagonists
Difficult to
would
make
be,
it-
it's they're already there. GnRH antagonists are there for ovulation induction, for IVF management, but they are short acting. So you need to give multiple injections there. So that's why GnRH antagonists are not used. So GnRH analog definitely is the treatment of choice.
Choice.
Yeah. Next.
So next, the FSH is
So FSH is the better
Marker
marker of onset of puberty or LH. So is FSH a good marker? So it's the LH which is a better
Better
marker
marker.
in that regards. Next.
So the next question is low dose radiation can cause precocious puberty
So low dose radiation to what?
in the brain, cranium.
So low dose cranial radiation, not the ovarian radiation. So low dose cranial radiation, will it cause precocious or delayed puberty? That's the question.
Yes, sir.
So we all know, and what do you mean by low dose?
The low dose is usually less than 12 or 15 GV.
So generally less than 12 or 15, you won't have anything. So around 18 gray and onwards, you will have the hypothalamus, which will have an effect in that hypothalamus inhibition will go. So you will have precocious puberty. But if you have a very high, around 30 or something, your pituitary will go and then you will have delayed puberty. So yes, low dose radiation can cause. So you need to be more precise in terms of your question. It can cause precocious puberty. Carry on. So is there any answers? Anybody is answering now?
So the next is red glistening vaginal mucosa suggests recent estrogen exposure.
So I think this we have discussed that red and pale. So if you have a red mucosa, it means
And
no
not
exposure. Pale means estrogen exposure.
Next is exogenous estradiol administration can cause precocious puberty.
So yes or no, of course, The body is not concerned where the estrogen is coming from, whether it is coming from the oral acceptance, whether it's because of local application, whether it's coming from the ovaries, it doesn't really matter. So all of them will have the same effect. Next.
So the next one is the last one, the isolated
Vaginal bleeding
bleeding
indicates a
indicates
local
local
cause.
cause.
So, which is true from that
Right.
perspective. I think everybody is right. So let's see who has given the answers here. So yeah, so a lot of people are engaged and they are mentioning about these answers. Dr. Dinesh, Dr. Ekta, Dr. Salam. So thank you, Alappan, for making a very, very interesting quiz, which was there. And that brings us to the end of our session on precocious puberty. Every month we will have one now on pubertal disorders as far as PG lecture series is concerned. In the next couple of weeks, we're going to have a very interesting advanced pediatric endocrinology symposium, and most probably we'll be live streaming that as well. So you should all join on that. Meanwhile, you can have a look at our resources, the books, the courses which are available, and the mobile application which are there in terms of pediatric endocrinology. So I think I'll thank all of you for patient hearing, and we will join again in that regard. I think there was one question which was pretty significant in between. I'll have a look at it, and then we will go on that. Dr. Salam is saying a challenging case, precocious puberty, 6-year-old girl. Consulting for pubic hair, height is normal, weight is slightly more, BMI 16, pubic hair 3, breast stage 2, bone age is normal, DHEAS is normal, 17 OHP is also normal. So I think most of these parameters are normal. I would probably say that we should hold on in that regards without doing too much workup in that regards. There is breast stage 2. But the other parameters do not really show that we have got significant estrogen exposure. The estrogen is very low, LH is very low. So better to hold on in this case and follow up rather than doing any more workup, Dr. Salam, in that ceremony.